Welcome, everyone. My name is Jess Posner, and I am the Director of Virtual Programs and Membership Services at the YMCA of Central New York. Thank you so much for joining us. It is my pleasure to welcome you to the final event in our month-long educational series with Syracuse orthopedic specialist, also known as SOS. I'd like to extend a special thank you to all of our speakers and to everyone at SOS and the YMCA of Central New York who made this series possible. So without further ado, I'd love to invite Dr. Battaglia to turn his video on. All right. Dr. Battaglia is the head of the SOS Sports Medicine team and a board-certified, fellowship-trained orthopedic surgeon with SOS, specializing in the treatment of sports injuries of all types, with a particular focus on arthroscopic and reconstructive surgery of the shoulder and the knee. This includes treatment of rotator cuff and instability problems of the shoulder, as well as the treatment of ligament, cartilage, and meniscal injuries of the knee. Dr. Battaglia is the lead orthopedist for the Syracuse University football team, a member of the U.S. ski and snowboard team physician pool, and team physician for numerous area colleges and high schools. So without further ado, the virtual stage is yours, Dr. Battaglia.
All right. So thanks for having me. I'm Todd Battaglia. I'm from Syracuse Orthopedic Specialists. It is doing some sort of automatic slide forward, I think. Hold on. Maybe I just touched it. All right. Anyway. Just a little bit about me. I'm local. I grew up in Marcellus. I have my credentials there. I went to college in Massachusetts and then medical school in Buffalo. Did a master's degree in surgical research and orthopedic residency in Virginia, and then my sports training in Boston. As you already said, I take care of a lot of local teams. My particular interest is shoulder, knee, and cartilage stuff. The talk I was given here was sort of a fairly vague talk about how to prevent injuries. So I had a hard time putting together exactly what that would involve. So it kind of got me thinking about where we're at, and we're seeing a lot of folks kind of breaking out of their hibernation, both from the winter and from the last year or so of COVID, where their gyms and their sports leagues and their pools and everything have been closed for more than a year now. Not only have they been inactive for a while, but they're also carrying a little bit of extra weight. There was an article in the New York Times the other day that said apparently the average American put on 2 pounds a month during the COVID shutdown. So over a year, that's a lot of folks who have gotten pretty out of shape and are just starting to get going again. So we are seeing a lot of folks come in with not true traumatic injuries, but more what you would call either overuse or disuse injuries. So instead of a sudden event where they've torn something or fractured something, this is gradual onset stuff from smaller subclinical injuries. And so I figured maybe it would be useful to talk a little bit about some of the things we're seeing. And then I hope it would evolve into mostly or a lot of question and answer stuff. So in terms of what we mean when we talk about an overuse or a disuse injury, this is a tissue that has not been subject to a maximal load and just gives all of a sudden. It's a repetitive submaximal load, and essentially the structure is eventually fatigue, and that might be a tendon in terms of tendonitis or a partial tear. It might be a bone in terms of a stress fracture. And then when this sort of injury or inciting activity continues, the body doesn't really have an adequate amount of time to heal that subclinical trauma. And as it progresses, it can actually reach a point where there's a true structural derangement, whether that's a broken bone or a torn tendon. A lot of factors play into this, some of which we can control and some we can't. Obviously, prior injury is one of the higher risk factors, particularly when it comes to certain ligament and tendon stuff. In terms of what we've all been doing the last year or so, nutrition and inadequate conditioning are certainly going to play a role. And then I use this talk a lot for some of the pediatric and high school athletes as well. And, some of their overuse and sort of specialization type injuries. We talk a lot about the psychological factors. Things that are outside your body that also play a role in how much these things develop include your training progression, how much rest you give your body and these tissues to recover, equipment issues, improper technique, whether that's running or throwing or swimming or whatever it may be. Some other sort of environmental situations, like what kind of surface you may be running on. And then obviously there's pressure even on the adult level from training groups and coaches and those things that may sort of overwhelm common sense in terms of adequate recovery and appropriate training protocols. So we're not going to go through all of these individually, but just in general, some of the things I'm seeing more commonly right now in the office in terms of upper extremity overuse stuff. A lot in the throwers and weightlifters as we get baseball season going again, but also as the golf clubs start swinging, and volleyball for a lot of schools has been moved now to the spring. Just in terms of when I give this talk to the younger kids and the throwers, there is study after study that directly relates the number of pitches you throw per week, per game, and the number of rest days you get with the likelihood of developing some of these overuse injuries. And the same stuff, I'm sure, applies to adults as well. In terms of common stuff, rotator cuff, certainly I do lots of shoulder stuff, see lots of shoulder patients every day. The great majority of it is not surgical. Great majority of it is conservative treatment for things like rotator cuff and bursitis. At the elbow, certainly the medial and lateral epicondylitis, or you might know them as golfers and tennis elbow respectively. And then biceps tendinopathy, which can occur either at the top end of the biceps up at the shoulder or at the bottom end down near the elbow. In the lower extremity, obviously, this is going to be more on your runners and jumpers and endurance sports, as well as your cutters and pivoters in basketball and soccer and those things. We see a lot of anterior knee pain, whether it's what we call patellofemoral pain, I'll touch on that later, or whether it's a true tendinopathy, either of your quadriceps or your patellar tendon. Iliotibial band stuff, lots of what we used to call shin splints. I'll spend a little time talking about that. Achilles and plantar fasciitis stuff in the foot. So, the treatment for all these is going to vary somewhat. On your own, you all know your rice, and it's going to be activity modification or rest and ice and compression if there's swelling, elevation. There are some things you can do on your own in terms of making sure you're using the proper equipment. I can't really overemphasize the importance of cross-training. Folks who do one sport exclusively every day, all year, have hugely increased rates of injury. There was a study, I think it was the University of Wisconsin or so a year ago, that looking at high schoolers who play only one sport year round have about a 70% higher chance of getting injured than folks who play multiple sports. And it's obvious why. You use different muscles during those different sports. You're not subjecting any one muscle or structure to the same repetitive stress over and over. But the same is true for adults, even folks who like to run as their exclusive sport. They should be mixing it in with biking or swimming or elliptical on some of their off days to try to change up the stresses that their bodies are seeing. So the question that always comes up, and which is basically impossible to answer, is when do I see the doctor? Every situation is different. Every patient is different. Every person's pain tolerance is different. I tried to think of some general sort of guidelines to put on here and said to myself, if a few days to a week of rest doesn't get you back on the field, that's probably a reasonable time to think about seeing a physician. If there's any obvious true physical impairment, you're lifting, you've actually lost motion at a joint, or there's an obvious deformity or swelling, that's probably a reason to call up your orthopedist. And then the level of pain is obviously hard to completely judge. It's individual, but severe pain that keeps you awake at night, inability to bear weight or to raise your arm, I think those would also qualify for a sooner rather than later discussion with your physician. So preventing overuse injuries, we'll talk a little bit as we go through about more specifics here. It sort of touches on all those factors I mentioned earlier in terms of the things that can lead to overuse injuries. Obviously, you want to make sure you're using good mechanics and using the appropriate equipment and gear, whether that's your footwear for runners or whether that's your golf clubs are appropriately fitted for golfers. Nutrition plays a big role. Numerous studies showing that malnourishment leads to a much higher rate of injury. Training is the key to all this, not only cross-training and mixing up what you're doing, but also making sure you're following a very well-prescribed and gradual training program, especially as you try to come back from rest periods or start up a new sport. Year-round conditioning simply refers to that obviously after downtime, you're going to be more prone to develop an injury again. So the more you can stay in shape year-round, and the more, if you do take an extended break, you gradually increase back, the less likely you are to suffer an injury. Stretching I put down there with question marks because stretching is actually a fairly controversial subject in the injury prevention world. This again just touches on what we typically recommend in terms of ramping up a new activity or after a long layoff. They usually tell folks to not increase by more than 10% per week, whether you're talking distance or time you spent working out. And that can be fairly frustrating to someone who wants to crank it up. Be going 20 minutes and only going 22 or 24 minutes the next week. It's a slow progression, but it's the smart thing to do. So in terms of stretching, I put in a few slides of this. In terms of proper stretching, you should get warmed up enough that you break a light sweat. You can kind of mimic the sport you're going to do. If you're going to be running, you can go out for a very slow paced jog around the neighborhood or around the driveway. You may want to just do some jumping jacks or some marching. When you finish warming up and are doing your stretching, standard stretching technique usually involves going just to the point of resistance. It should not be painful, holding that for anywhere from 20 to 30 seconds, not bouncing, and repeating that at least 3 to 4 times with a little bit more pressure each time. But the question in our orthopedic literature is whether this actually works. And it turns out when you get down to the nitty gritty of stretching, there's actually probably 4 different types that have been sort of classified or described. Most of what we think of as stretching is what we call static stretching, where you're basically stretching to the point of slight discomfort and holding it. There are some other types like bouncing stretches, dynamic stretch is what you might do when you're swinging your arms around, trying to warm up to throw or swing your golf club. And then there's even a little bit more complicated, this PNF stretching is where you stretch, but simultaneously are trying to contract and relax the muscle. Those bottom 3, there's not a lot of literature on. Most of the studies have pertained to that first static stretch, which is, what we all did growing up in gym class and before going for a run. The theory is that stretching obviously increases your flexibility, makes your muscles more supple, also trains your nervous system to sort of tolerate stretching a little bit. And that by increasing the flexibility, you sort of increase the muscle's ability to absorb energy so that as you run, they aren't traumatized as much. They have a better ability to, for instance, absorb the energy when you land on the pavement or when you're pushing off. So that's what happens in theory, but the evidence actually shows, I won't say overwhelmingly, but certainly leaning more towards than away from, that stretching right before you exercise doesn't do much to prevent injury. There have been a few very, very large studies that have found essentially no effect, and there was one recent study that sort of found a hint of effect of preventing or decreasing the rates of injury when you stretch right before exercise. The other thing we all think too is that, stretching is going to maybe prevent that muscle soreness I get a few days after surgery. That's what we call delayed onset muscle soreness. There's actually no evidence that it does that as well. Where stretching does seem to have perhaps its effects or its usefulness is stretching outside of the exercise period. So you have separate stretching sessions or you stretch on your day off. That may help increase some power and speed and reduce your injury. But the evidence is actually pretty nebulous about all this. So even though I'm a believer in stretching, mostly because of the fact that I feel better when I stretch, there's not a lot of data to actually support it. So I was going to get into a few of the more common overuse injuries we see. I can take a break and sort of field some questions now, or just keep going and we do stuff at the end, whatever people might feel is better.
I'd say let's go ahead and keep on going and we'll collect all the conversations at the end. How's that feel?
All right, let's do that. So first one I put on here and spent the most slides on are what we used to call, or what people still call, shin splints. Shin splint is a fairly non-specific term. It actually can refer to some other lower extremity issues as well. So we don't in the medical world use it much anymore. We tend to call this medial tibial stress syndrome, which does a much more descriptive job of what's actually happening. Your tibia is the larger bone from between your knee and your ankle. Medial just refers to the fact that this usually occurs on the inner or the medial side, and it's a stress injury. So, for better or worse, orthopedic surgeons aren't rocket scientists. We call it medial tibial stress syndrome. Basically, what it involves is a process where, again, that repetitive stress on that edge of the bone ultimately leads to inflammation within the tissue and where the tissues attach, and which can then sort of progress and propagate and gradually develop into an actual damage to the bone itself. And if you look at sort of classic medial tibial stress syndrome, the picture there on the right shows you where you feel this. It's basically on the inner side of your leg, right along that ridge of your tibia, of your shin bone, and almost always between the middle and distal portions. That is textbook medial tibial stress syndrome. Signs that it's not that or is a variant of this would be a different location, would be any sort of pain, numbness, or tingling that go down into the foot or the toes. Knee pain is typically not involved with this as well. And what this comes from is one of the muscles that's in the back of the leg called your tibialis posterior. It's basically an overuse and overstress of where that muscle attaches to the bone surface, basically the tree bark around the bone. And so that creates a gradual inflammation, which can then start to break down the bone underneath. And these come in big varieties, right? You see people who have minor soreness that they can run right through. It's just a little annoying. You see people who get so bad they can barely walk. We've got to put them on crutches for a time. So why do people get this? No one really knows. Everybody gets it. I see kids from 12 to 70 that get this stuff. There might be some biomechanical factors that increase your likelihood. Flat feet, or what we call pes planus, which is also sort of associated with overpronation. That's people who sort of roll their foot inward during their running stride. Maybe it relates to a slight difference in leg lengths. Maybe it relates to the type of shoe wear you're using or the surfaces. There have been a lot of papers looking at these things, all kind of suggestive, but not really conclusively showing any of these things. Does asphalt make people more likely than a rubber track? We honestly can't say that for sure. There are definitely some factors, particularly in females, that lead to stress injuries in general, and particularly this kind of shin splint type picture and stress fractures in the lower leg. This is what we call that female athletic triad. Excuse me. Females who work out, exercise at very high levels are a very high tendency for becoming malnourished. Any association with eating disorder obviously will increase that malnourishment. They can develop menstrual irregularities, and because of all these things, they actually start to suffer in their bone density. They start to develop lower bone density, which obviously is going to increase their chances of quote weak bones and stress fractures. So when we see somebody who we think has this MTSS, we almost always will get a set of x-rays in the office. X-rays are hopefully going to be negative. Even if you have a stress fracture, which is not MTSS, that is MTSS plus, a lot of these stress fractures don't show up. So if your x-rays actually show something, you've reached a stage where there's something pretty significant going on. And then depending on how bad the symptoms are bothering the patient and what sort of goals they have, what athletic things they're committed to over the coming weeks, we'll make a decision about getting further imaging like an MRI or a bone scan. I tend to be fairly conservative and not get this right off the bat unless there's sort of extenuating circumstances, because the truth is it doesn't really change much about what we're doing. The treatment will be the same. It just gives you a better idea of how bad the problem is and how much time it might take. So it doesn't play an immediate role in deciding what to do for a lot of these. So regardless, actually, let me go back to that one. So what we're seeing here on this MRI, I think, is my mouse arrow visible to you guys?
Yes, sir.
Yeah, so there's an arrow right on the picture here. Bone on an MRI typically looks sort of gray-black. And so this is obviously your shin bone and normal bone below. This middle third region where you're seeing white, you're essentially seeing inflammation within the bone. So this is sort of the hallmark of that MTSS or that bone inflammation. And when we get to the stage where it reaches stress fracture, you'll actually see some pictures where you'll start to see some cracks in the bone here. But when we get this picture from an MRI, we see inflammation, but we see no actual crack. We're at that tibial stress without reaching a stress fracture stage. So at this stage, it's always non-operatively, or 99.9% non-operatively. Obviously, activity is going to need to be modified, usually cutting back completely on impact activity at the minimum. No running, no jumping. Maybe if they don't have pain, I'll let them get on the elliptical or ride bike, but anything that causes pain is irritating this, needs to be stopped. If there's any obvious biomechanic issues, if they need arch supports or something like that, we'll talk about it. Anti-inflammatory modalities in terms of ice and medication. Stretching primarily to basically try to relieve some tension on that posterior tibialis muscle, which is the source of all this. And then we monitor symptom improvement. And as that happens, we have to go very, very, very gradually in terms of getting them back to their activity level. It may take 4 to 6 to 8 weeks to do this sometimes. As I said, surgery is incredibly rare for this. I've performed maybe in my 16 years, 3 to 5 surgeries for people who just have intractable shin splint type pain. And the surgery basically revolves about going in and sort of loosening or releasing that muscle attachment, basically to lessen the pull on the bone. And I will tell you that it is not a home run surgery. It is a last resort. We tell people it's about a 2/3 percentage that actually get what they would call an excellent result from this. So we really try to avoid it. Not many of us like doing surgeries that aren't highly successful, and this is not one of them, unfortunately. The reason we get all bent out of shape and just don't say, hey, you got a shin splint, go run through it, is that it continues down this spectrum if it's left untreated. So it started with simple inflammation in the muscle and the tree bark of the bone. It progressed to inflammation in the bone itself. It then can progress to little microscopic cracks in the bone or early stress fractures. And if it goes long enough, this doesn't fool anybody. You can obviously see the actual macroscopic cracks in both of these tibias from ongoing medial tibial stress syndrome that has reached stress fracture phase. And you see this sort of lip coming out on the bone here. That's how we know that this is not an acute fracture. This person didn't get hit in the shin with a baseball bat yesterday. This is extra bone that the body has been making, trying to heal this process. It just hasn't been able to do it fast enough or well enough, and the fracture has occurred regardless. So this is actually the body's healing response sticking out like there, but it's been an unsuccessful healing response. So this is an obvious one. We can pick this up on x-ray. As I said, not all of them are this obvious. If we have a real concern for a stress fracture, a lot of times the x-rays will still be negative and we've got to get an MRI or less commonly a bone scan. So now we've reached that tibial stress fracture thing. Again, these are usually non-op. As I said, we often don't even see them on the x-ray. This classic MTSS or stress fracture, again, is that inner side of the tibia. And the reason we don't get too bent out of shape here is this is what we call the compression side of the bone. When you're walking, that portion of the bone actually feels compressive forces squeezing it. So it's not likely to have a catastrophic break in half or anything. We usually have to put them on some kind of protected weight bearing, maybe cast, usually more like a boot. Got to follow this with x-ray to make sure it heals. And this can be even longer. Again, maximum 10% rule, it can be months. Again, surgical role, if someone gets repeated stress fractures, might be that soft tissue release again, but very rarely performed. What should worry you a little bit more? So atypical MTSS or atypical shin splints are any that occur along the front ridge of your shin bone. So if you run your finger down the front of your shin, sort of where you'd get kicked in a soccer game, that is not where classic shin splints occur. And as you'll see, we get a little bit more worried about these than we do about the other. This is thought to start from a different muscle. This is actually a muscle that's in the front of the leg and works to bring your ankle up. So you sort of use it when you're using your toes to clear as you swing your leg through when you're running, rather than the other muscle, which is more of a push-off muscle. And really, although this occurs, 2 centimeters away from where the other shin splints we discussed are, this is a totally different animal. And the reason is the front of your shin bone is the tension side of the bone. That's the side of the bone that's actually getting pulled, separated when you weight bear. So these types of shin splints are absolutely notorious, not only for taking a very long time to heal or maybe even not healing at all, but for also progressing into what we would consider catastrophic failure. And the hallmark of these on the x-ray is what we call the dreaded black line. So you look at this x-ray over on the left and, without a magnifying glass, it looks pretty good. There's no obvious cracks on there, no bone thickening. This would look pretty normal from a 30,000-foot view. When you zoom in on it, though, and this is the same x-ray, you see these very faint little black lines coming down the front of the bone right here. This is the dreaded black line along the front of your shin bone. And those are little microscopic cracks starting there. And those are notorious for progressing from a little crack to a true complete break of that shin bone. And this is a complete discontinuity of that tibia. those of you who follow NCAAs, this was a fellow named Kevin Ware 5, 6, 7 years ago who had a stress fracture in his tibia and either didn't report it or maybe he wasn't having much pain. I don't know, but in the middle of an NCAA game, that became a complete open tibia fracture. That's his shin bone sticking out of his leg right there. So this started with a stress fracture, believe it or not. That's why we get very worried about these things. And so when we see these are often treated surgically. And there's a lot of different surgeries that have been described, trying to go in and scrape it and pack bone graft in there and stuff. But most commonly what we do is actually rod the tibia. So this is a very long, full-length metal rod. It's about 10, 11, 12 millimeters in diameter, depending on how big the person's bone is. It's put in from the knee, and it basically shish kebabs right down the center of the knee. It's inside the canal. So that will basically shield this. You don't have to worry about this becoming a complete fracture anymore. It usually starts to absorb enough of the energy that this thing can now heal. They can walk on it immediately. That is something I probably have to do a couple times a year for folks who show up with this different variant of stress fracture. Finally, we see these stress fractures, lots of other different places about the leg. So I'm focused on knee down. We see them in the fibula. I just saw a high school kid with one the other day. He sort of negotiated with me because he had a week and a half left of basketball. So we kind of buried our head in the sand and let him finish the season because his pain was tolerable. And now we've got him shut down completely, but this is not usually a surgical issue. We can see him up near the knee. This is a little, what we call tibial plateau fracture. So this is the same shin bone, but it's up right below the knee joint. You can see that sort of wiggly, thickened bone as the body tries to heal it. They can be in back of the shin bone. This is one on the inner side of the ankle where that bump sticks out on the inner side of your ankle. Here's a healing one. It can happen anywhere. The other one, I did not put any slides on here, but the other notorious and very dangerous one are hip stress fractures. So stress fractures that occur at the top of your femoral bone up where it enters the hip, right by the pelvis. And this is typically very significant groin pain. So if we've got a lot of runners in the audience, groin pain that lasts, particularly painful when just weight bearing or walking, should not be ignored. That can turn into a catastrophe if that becomes a complete break. They don't heal very well. You can end up with a hip replacement at 30 or 35 when this happens. So femoral neck stress fractures are very, very significant. And then here's just another example of one up by the knee where the x-rays look pretty good. You get that MRI, you see all this inflammation through the top of the shin bone, and this you can see a very clear, incomplete stress fracture coming across there. So these are starting to rain down on us as people start to get out there running in the good weather and coming off their winter layoff here. Other common stuff we see about the knee, obviously we see a lot of tendonitis and kneecap type stuff. Patellofemoral syndrome is sort of a non-specific term that sort of just refers to kneecap pain, if you will. The classic definition of patellofemoral syndrome is actually cartilage inflammation. It's the cartilage under the kneecap. And we see it a lot in kids, actually. Classic symptoms for this are pain with squatting, pain going up and down stairs. The theater sign is when you've sat for a long time, whether it's a movie theater or a car ride or whatever, you start to get that pressure from the compression on the kneecap. This is a purely non-operative diagnosis. Same sort of stuff, anti-inflammatories, rest, ice, steroid injection can be very good for this. And then particularly focusing on quad strengthening is important because the quads sort of help elevate the kneecap to a microscopic degree. They help take pressure off the back. Almost identical to this are the symptoms you get with tendonitis, either right above or right below the kneecap. So either your quadricep tendon, which is the tendon right attached to the top of the kneecap, or your patellar tendon attached right to the bottom. Not only runners, but jumpers, particularly basketball and volleyball players, very commonly get patellar tendonitis. Again, same sort of treatment regimen, non-surgical, great majority of the time, unless the progression has reached a point where there's actually tendon breakdown and microscopic tears starting. And then I thought this was a good one to just mention PRP. I don't know if anyone out there is familiar with PRP. It stands for platelet-rich plasma. And what it is sort of a pseudo growth factor type of injection. It's not, I'm sorry, it's sort of a pseudo stem cell type of injection. It isn't really stem cells where we're removing complete cells from your bone marrow or from your fatty tissue. This is simply a blood draw in which we centrifuge your blood and separate out the layer that's more rich in the growth factors, essentially. And that's injected then into spots of injury. PRP is getting thrown around a lot. It's relatively new, and people are trying it for many, many different things, a lot of which it does not appear to help. It doesn't make a rotator cuff surgery heal faster. It doesn't help an ACL surgery heal faster, but it has shown some decent evidence in two sort of different categories. One is lower grade arthritis type symptoms. It seems to have a longer lasting effective relief than a steroid shot does or a gel shot. And then the other is it seems to be fairly useful for chronic tendonitis type issues. So patellar tendonitis, Achilles tendonitis, tennis elbow, golfer's elbow, those kind of things. So this might be a place where that PRP injection proves itself to be useful. We don't do a ton of them because one of the main issues with it is still viewed as an experimental treatment by insurance companies, which just means they don't pay for it, and it is relatively expensive. So I wouldn't say I do a lot of PRP injections, but in the right situation and with the right patient who understands the risks and benefits of it, it would be something we might consider for a chronic patellar tendonitis. Just lateral to that, any runners out there have probably had their share of IT band or iliotibial band syndrome. This is actually a friction syndrome. If you look at that picture far to the right, there's a very long tendinous structure called your iliotibial band, and runs all the way from your pelvis down to your tibia bone right below your knee. And it's a site of attachment for lots of muscles. Some of your quad comes off it, some of your gluteal muscles attached to it. And unfortunately, the way our leg bone, our femur bone is shaped, it has a flare at the bottom such that when we run and bend and straighten our knee, this tibia, or this IT band, sorry, kind of has to move from front to back. And you develop this friction inflammation underneath it from this rubber band sort of going back and forth over the bone. It's pretty pinpoint, usually right on the lateral side of the knee. Very common with activities that involve a lot of bending and pushing off, so running and stairs. This is outside the knee joint. So unlike a meniscus tear or something like that, there shouldn't really be any fluid buildup inside the knee. This is all an external thing. Again, very, very, very rarely a surgical issue. Surgery for this is not great. We try to lengthen that IT band a little bit so it's not as tight. But most of the time we get this better without a surgery. We use something called a counterforce strap, which basically goes just above the knee and shifts the pressure off that area of friction. Same thing as we talked about elsewhere: rest, ice, anti-inflammatories, very gradual return to activities. And then stretching in this situation definitely helps because, again, that friction syndrome comes from that tight band moving back and forth. And if you can stretch that out, the friction will obviously be less. And this is sort of your classic IT band that most runners do to try to keep from getting an IT band syndrome. This is the U.S. Naval Academy's protocol for combating IT band syndrome because those guys are running all over the place. If anybody needs it, you can look that up. Last one I put on here, just worth a slide or two, is plantar fasciitis, the other runner's bane. This is heel pain that occurs right on the inner side at the back of this bottom of the foot. So we're looking at the foot from the bottom here. This is obviously your big toe moving over to small toe. This is your heel. It occurs back of the foot off to the inner edge, right along the edge of this band called your plantar fasciitis, which is a tight fibrous band or ligament that helps hold some of the muscles and helps hold some of the structures around the toe. Very classic plantar fasciitis is excruciating pain when you wake up in the morning because you've been sleeping with your feet sort of pointed, relaxed position down. It tightens up overnight. You go to walk in the morning. Your first steps out of bed, it's just so tight, it kills you. Then as you get moving, it tends to improve. But then once you go for your exercise or your run and it gets all inflamed again, then your pain is worse. This can lead to micro tears, which can take a little bit longer to heal. But most of the time, this is combated through making sure you got a heel cushion or an orthotic, stretching, tapes and supports might help. The classic stretch, which I put, or sort of stretching and modality technique, is to keep a lacrosse ball or a can of that frozen OJ concentrate in the freezer, and you get it out and you put it under your foot and you sort of ice massage by stepping down on it and rolling back and forth, sort of combining the ice and massage. The other thing that can help is a night splint, which if you've ever had one, it almost looks like a stocking with a very, very long toe that you then pull up and attach to the front of your shin bone. So it's keeping your plantar fascia stretched, like think of just like an Achilles stretch throughout the night, so it doesn't have a chance to tighten up. Injection for plantar fasciitis is kind of controversial. I had a terrible case myself when I was in medical school and running a lot, and I could do nothing to get it better until I had a cortisone shot, and then it was almost immediate. I was back running within a week or two. However, I can tell you not all foot and ankle guys share that opinion. Some feel that cortisone, which truly is not all that healthy for tendon structures, might lead to a higher rate of actually tearing the plantar fascia because it weakens it. Some others haven't really expressed much concern about that. So injection for plantar fasciitis is going to be a physician-to-physician determination and recommendation. Next thing, I moved on to just common overuse injuries of the upper extremity. Tennis elbow and golfer's elbow we talked about before. They are essentially the same processes, just occurring at different locations on the elbow. Golfer's elbow is on that medial bump, and tennis elbow is on the outer bump. You don't need to be a golfer or a tennis player to get either of these. These are just common terms used because the muscles used in those sports tend to place excessive stress on these injuries. So the muscles in the front side of your forearm, so on the palm side of your forearm, they all attach at that inner bump on the elbow. And so exercises or activities that involve flexing your wrist or turning your wrist from palm up to palm down, as you would as you follow through on a golf swing, those all pull those muscles attached up at the inner side of the elbow. And when that gets chronic inflammation and breakdown, that's golfer's elbow. All the muscles on the back side of your forearm, or that attach to the back side of your hand. So these flex your wrist backwards, they straighten out your fingers. So these would be muscles you use when you snap your backhand in tennis. Those all attach on the outer side of the elbow. And when that process occurs there, that's what we then call tennis elbow. But I would say, the great majority of folks I see for these things, it isn't from tennis or golf. It's from another sport, or it's from a work-related activity. They work at UPS and lift all day, or, who knows, something like that. In terms of what is happening, this again is just a chronic tendonitis. You get inflammation build up where those tendons attach to the bone. As I said, it comes from repetitive wrist and forearm motion. It can progress to actually what we call micro tears or microscopic tears, where if you get an MRI, you can see small breakdowns there. As far as I know, it's never led to a macro tear where the entire attachment comes detached. That would take a more significant trauma. Hallmarks of treatment, in addition to all the other things we've talked about, this is one where a specific brace is very helpful, an elbow strap or elbow brace, which goes below the elbow by a few centimeters and is not usually just a strap. There's also usually a little bit of a prominence or a bump to that. So you can either put more of a pressure point toward the outside or toward the inside, depending on which one of these you're dealing with. Its entire purpose is to sort of shield that area so that when you do those motions, those muscles are sort of being tethered short of their attachment site on the bone, and therefore the bone and the tendon attachment don't feel that stress and that pain. In addition, warm up, stretching to reduce tension helps there. Technique, all that kind of stuff, the elbow strap. Injection is an interesting one for this. I do a fair amount of injections for this. I do use steroid because it helps decrease the inflammation. This is not an issue where we're worried about you developing a big tear. But it turns out that if you do the injection with nothing but saline, it helps almost as much as using steroid. And that is because done properly, if you have a tennis elbow or a golfer's elbow injection, we use what's called a needling technique. And what that means is we actually take the needle and try to poke into that damaged area of tendon 5 or 6 or 7 times. And what we're doing is creating a little bit of bleeding and some channels for blood supply to reach that tendon and try to heal it. So you can do even a dry needle or a sterile or a saline type needle. Not that you should do it, we could do it, and achieve almost as good results as you can with the steroid. This is another instance where we almost never operate on it. And the reason is almost every study shows that eventually it gets better without surgery. It also shows that the patients who have surgery and don't have surgery 2 years later feel almost exactly the same. And the surgery itself is not a huge success. A lot of people get it. They say they feel better, but they still have some symptoms, and it's still just a matter of time until it gets better. So although I get suckered into this a few times a year, it's not one of my favorite surgeries to do, or even close to it. So we try to avoid that. Shoulder stuff, as you all know, throwing sports, weightlifting. Again, we're still in that family of tendonitis. Rotator cuff. Rotator cuff pain usually is at the lateral shoulder. So if you kind of run your fingers along your collarbone and come to the edge of the bone right there, it's sort of down that side. And you can actually very classically feel it anywhere down to the elbow. It's very common to have a rotator cuff injury in the shoulder. And the patient comes in and says, yeah, but my pain is actually in the middle of my arm off to the side. It's just the way we're hooked up, and that's where you feel the referred pain. Biceps tendonitis at the shoulder is a little bit different. That's usually much more towards the front of the shoulder, almost where the groove is between your chest muscles and the shoulder. And they also obviously hurt slightly differently. Your rotator cuff is more responsible for lifting the arm to the side, whereas the biceps is more in charge or involved with lifting the arm forward or flexing the elbow. So you can get a little bit of a hint there. Rotator cuff stuff can and most commonly comes from overuse, but you see people occasionally who know the minute they did it, they lifted something too heavy and had that pull sense in the shoulder. Sports, javelin throwers, overhead athletes, weightlifters. And there is this thing called the impingement phenomenon, which is this little picture to the bottom right are 3 diagrams looking from the side at your acromion bone. And your acromion bone is the bone that forms the roof directly over your shoulder. It's just to the lateral side here where you kind of feel that drop off. That's your acromion. And we're all born with a little bit of a different shaped acromion. This nice flat one is called a type 1. And that's what's ideal because it leaves lots of room for your rotator cuff to exist right underneath it. If you look at this picture, you've got your ball in the socket and you've got your acromion over top, and the rotator cuff is sandwiched right between those 2 bone layers with very little clearance. So having a nice, straight, flat, wide open acromion is great. Type 2 has sort of a curved appearance, and a type 3 is what we call a hook. And the thought is that as you progress down this sort of shape spectrum, the folks who are born with one at the lower end of the spectrum are more prone to rotator cuff irritation and impingement. There's less clearance down there when they bring their arm up in certain positions. It's getting pinched between those 2 bones more acutely than someone with a nice flat one. So sometimes our surgeries, whether it's a rotator cuff tear we're fixing or people who just have chronic impingement, involves going in and flattening this acromion with a burr, like a dental burr type of thing. That's called a decompression. Simple impingement or rotator cuff tendinopathy, again, almost always non-op, at least to start, anti-inflammatories, lots of injections done for this, steroid particularly. It also allows you to do your rehab better. And rehab is a big part of this because rotator cuff strengthening actually helps open up that space just in the way the muscles are aligned. It has the effect of allowing more room for the rotator cuff to exist. And so you can look up rotator cuff exercises. I hand out copies of these to 30 patients a day when I'm in the clinic, just so they can do home exercises for this. So I was going to take a brief breath for 2 seconds, and then unless there's questions, I got one more thing I was told to speak about, and that was exercising outside. And I didn't know if that referred to telling y'all to wear reflective clothing or what side of the street to run on, or I figured that stuff's kind of obvious. So I figured with the warmer weather coming, we'll just talk quick about some environmental issues. The first one, which just a few slides on this, is how to deal with the heat. People get all gung-ho, first nice day, they go out in 70-degree weather and run further than they have in a year. Heat illness is a pretty severe thing. If we've got any racers, marathoners, half marathoners, you can't run one of those races without seeing multiple people being treated for heat illness afterward, even in cold weather. It's pretty important. It's the reason why there's a medical crew present at almost all these races, because it can have some pretty devastating side effects. So heat illness causes, or to even go behind that, evaporation of sweat is the main way our bodies get rid of heat, right? So when our bodies are trying to regulate the temperature and we're generating heat either internally from running or we're absorbing heat externally from sunlight, the way we get rid of excess heat and maintain our body temperature between 96 and 99 or whatever you want to call it is through sweating. And what you'll see in some of these is that the heat illness can actually cause a derangement of our sweating processes, and then the whole system shuts down. So efficient sweating is actually part of the training process. As you get acclimatized to heat and exercising in the heat, your body actually goes through some changes in terms of how your heart pumps, how your hormones circulate, and how your sweating works to get more efficient at getting rid of heat loss. So just like you would train your muscles when you're getting back into shape, you actually have to train your body for getting used to working out outside in the hot weather again. We're going to go through some of the symptoms of this so you can be aware of it. And it turns out that heat stress on your body can actually be cumulative. So if you had a little bit of a heat issue yesterday, but nothing reaching the point that you needed any attention, and you go out and do the same thing a day or two later, your threshold for having a heat issue is actually lower because of the heat stress you'd suffered a few days before. Your body goes into a bit of dysregulation with all this stuff. So when do we really get worried about it? This is very, very, very conservative numbers. Special care for more than 90 degrees Fahrenheit out or 70 degrees humidity. I can tell you from experience, this happens at temperatures much lower than this. I take care of SU football, and we have kids who get heat illness, our first day out in April because they're covered in layers of pads and clothes and the whole deal. So there's something that's a little bit more accurate than just looking at the thermometer, which is called the wet bulb globe temperature. And you actually need a little special piece of equipment to measure this, but it takes into consideration not only the ambient temperature flat out, but also the humidity in the air and the degree of sun exposure, how bright the sun is that day. And so based on this, we actually modify practice based on these numbers here. If it gets high enough, which is typically 80 or so higher in the wet bulb globe temperature, we make some changes to what happens in terms of practice and watering and practice time and the whole deal. So the other thing we monitor and that you can do too is how much water weight you've lost. It's an indication of how much sweating you're doing and how dehydrated you may be. So players get weighed every day during spring training and during August training to monitor what their pre and post practice weight is to see how much weight they've lost. And the other thing I didn't put on here is every single urinal in the bathroom has a color chart above it so that the urine color can be monitored. And a well-hydrated player or athlete should have urine that is clear or light yellow. If you're getting into a more of a rich yellow or any sort of amber color, you are dehydrated and you're at a higher risk for heat loss. Heat illness comes in a few different flavors. The most basic and benign one is what we would call heat cramps. And we think this comes from just this excessive salt loss from sweating. This can occur in people who even are in good shape and have been training in the heat. Usually occurs in the larger muscles of the thighs, your quads, your hamstrings, but it can include any others. I've seen it in abdominal muscles. I've seen it in back muscles. This is relatively straightforward. It's rest, massage for cramping, rehydration, salt solutions, and this is self-curative here. This does not really require a lot of medical attention or fancy treatment. The next level up from that, though, is what we call heat syncope. So here you're exercising in the heat, and one of the ways your body tries to lose more heat to regulate its own body temperature is it dilates your blood vessels, especially in your extremities. The more dilation, the more blood flow can go, and the more heat loss from the circulation that can occur. And we think this one happens simply because those blood vessels dilate and your blood pressure drops. And so you have sort of a fainting spell, essentially. This is also typically not something that requires a trip to the emergency room. People should know they feel lightheaded. That could be heat syncope coming on. They got to sit, they got to rest, they got to get some water in their system. But again, this is usually very self-limited and pretty easily self-treated. It is when we get past that stage that we start to get into the two major ones, which are going to be heat exhaustion and then the next one we talk about. Heat exhaustion is a scientific definition that occurs when your body temperature does not reach 104 degrees. 104 will be the next thing we talk about. But your nervous system has actually started to suffer derangement in how well it can get rid of heat. And so the keys to this are not just feeling a little bit lightheaded or like you might faint. This is actually fatigue. You feel weak. Headache is very common to feel nauseous or like you're going to throw up. Heart rate and blood pressure also change as well. The one thing that you will not see in this is any sort of neurologic changes. If you have confusion or any sort of altered level of consciousness, that's going to bump you up into the next level by definition. So heat exhaustion, if you can catch it, is treated by rapid cooling. These are ice baths or cool towels, rapid rehydration with oral. And if you're at practice, we're going to start an IV on you and get fluids in you, and rest. If you get a core body temperature that goes above 104, or there is any neurologic changes, that is by definition what we call heat stroke. So we were talking about heat exhaustion, now we're in heat stroke. This is an absolute medical emergency. It can cause brain damage and nervous system damage that are non-recoverable, irreversible. So this again is, as I said, is indicated by a core body temperature of 104 degrees Fahrenheit. There is nothing I like less than having to stick a thermometer in a football player's rectum in the middle of practice, but when it happens, it has to happen. And at this point, the body has lost all ability to regulate its own body temperature. So when this happens, sort of the classic picture is sort of the non-athlete. It's all these older folks who you hear about, unfortunately, passing away when there's a heat wave and there's no air conditioning in Arizona or whatever. In exertional heat stroke, this affects young, healthy athletes. It's not a medical condition that predisposes to them. It's not an enzyme issue or anything like that. It occurs in heat and humidity. It usually starts with profuse sweating, although it can actually change and the person stops sweating completely because they're in such dysregulation. Their nervous system just shuts down. And again, the hallmark is neurologic changes, confusion, altered level of consciousness, difficult arousing them, those kind of things. Treatment for this starts on the field. Immediately pack them in ice or ice water or whatever we have available. Cool IV hydration. They may or may not be in a stage that they can actually drink on their own, so they may have to get IVs with an inability to drink any water. EMS needs to be called, and they need to be taken to the hospital for more professional rapid cooling and monitoring of their neurologic symptoms. And if that doesn't improve, as I said, there can be brain injury that requires head MRIs. It can result in a difficulty regulating yourself in heat for many, many months after the injury occurs. This is a major, major issue. It's also the most common, it's the, I don't remember, second or I believe third, maybe most common cause of athlete death in the sort of 16 to 25-year-old age range. There's a cardiac issue that's more common. Traumatic brain injury from concussion type stuff is common, and then this one is right up at the top of the list as well. Only other thing I could think of to put in the environmental issue thing was sun protection. Skin cancer is as common as you can imagine here. Typically tends to occur in the areas that are constantly sun exposed and that you don't think of to put sunscreen on. So the top of your head for the bald guys and the edges of your ears and your face and your shoulders for folks who like to run in tank tops. Make sure you're using protection from both UVA and UVB. If you're a real sweaty guy, it may actually need to be carried with you and you reapply it at times during exercise. There is some evidence that your vitamin C and vitamin E, which are a couple of your antioxidants, can protect against sun damage. Sun damage occurs through injury to the DNA, and antioxidants help prevent some of that damage. And then people forget about their eyes as well. It actually turns out that UV rays contribute to the development of both glaucoma and cataracts. So making sure you're wearing sunglasses, particularly with top and side protection, is important as well. And I think I decided to shut up there and see if people have questions or anything else interesting we could talk about. I'll leave this slide up. I put my email address, and you can also access it through a little link on my website as well. So if people have any questions they want to ask, but maybe not in public or think of something later, feel free to email me. I was told the topic was, again, preventing injuries and exercising outdoors. So I'm happy to talk about anything you can think of on those topics or anything else I do for that matter.
All right. Thank you so much, Dr. Battaglia. What a comprehensive, wide-ranging, and informative presentation. We really appreciate your sharing of your expertise with us. And I'd like to take this opportunity to suggest anyone with any questions to go ahead and throw those in the chat and send them my way. And I am happy to ask them to you, Dr. Battaglia. It is right around 6 o'clock, so I just want to make sure that we respect your time. Do you have a few minutes for some questions?
Yeah, I'm totally free.
All right, wonderful. Well, I guess to get things started, I'd like to ask you what brought you to sports medicine, and more specifically, also your specialty within sports medicine.
Sure. So I don't know that I've got a real specific answer for that. I grew up playing a lot of sports. I actually played 2 sports in college. So, obviously when I ultimately decided to do medicine and orthopedics, doing something that allowed me to stay in that sort of athletic realm was attractive. In terms of orthopedics itself, orthopedics is a little bit different than some of the medical specialties. We're a very hands-on sort of specialty, especially when it comes to surgeries. I don't mean to demean what we do, but our surgery is very, it's sort of human carpentry in a way. We do a lot of sawing and use of plates and screws and repairing of damaged structures, which was very attractive to me. And within orthopedics, I liked the idea of working with folks whose goal was to get back to a high level of activity. Some of our guys are primarily joint replacement specialists, which I do some of as well, but that's a different patient population, or our spine surgeons. I liked hanging out on the sidelines. I like being part of a team. I like working with someone whose goal is 100% recovery, not to just walk again without knee pain kind of stuff.
Thank you so much. We have a question from one of our guests, and they would like to know about the nerve block for sciatica pain and if there are side effects for that.
So for those of you who aren't familiar, sciatic pain is basically nerve pain that radiates typically down the back of your leg. It can wrap around below the knee. It sort of follows the course of some of the nerves that come out of your low back. And there's actually a few different causes of sciatic pain. By far the most common is that some of the nerves that contribute to your sciatic nerve are getting irritated at the low back level, either from a herniated disc or a bone spur from arthritis or something like that. There are some other issues though, particularly runners are prone to get something called piriformis syndrome, which is where the sciatic nerve is actually getting pushed by one of the hip muscles, where it kind of dives through a couple muscles as it exits the pelvis. And as that muscle gets bigger and stronger from exercise, it can actually sort of squeeze the sciatic nerve. Injections are usually done for the low back portion. And what they essentially do is try to go in and put an anti-inflammatory type medicine around the area where the nerve is getting irritated to decrease any irritation or inflammation around that nerve. They are in general very safe. They are done by some of our partners we work with over at a practice called New York Spine and Wellness, and there's other folks who do them throughout town as well. They're usually done under some sort of imaging. You either need an X-ray machine or something else to make sure you're getting that needle exactly where it's supposed to be. They are pretty darn effective if the diagnosis is accurate. In terms of risks, I'll say some risks that are obviously quite serious, but they are incredibly rare. Obviously, you get poked with a needle, there's going to be a small risk of infection. Rarely happens, but you've got to monitor for redness and rash and fever and those kind of things. The other thing you'll very, very rarely see is if you have any bleeding internally where they put the shot. Obviously, if you collected what we call a hematoma, which is basically some bleeding under the surface, that in theory could put some pressure on the nerve or the spinal cord as well and lead to a more significant or a more emergency type of issue. But I don't do spinal injections myself, but I could not imagine that the complication rate is higher than a fraction of a percent with those kind of injections.
All right. Thank you so much. There's a question about a follow-up to that about the brittling of the bones with the sciatic injection.
Okay. Oh, I know what they're referring to. So it turns out steroids are not very good for your bone, or bones, I should say. And that particularly is true for people who take oral steroids. So if you've got any sort of autoimmune issue where you've been on prednisone for a long time, or you've got bad asthma where you have to take steroids for a long time, over the years, steroids actually do lead to osteopenia, which is thin bones, and is sort of then the next progression to that is what we call osteoporosis. It turns out that injections of steroids are much less worrisome. Injections pretty much stay localized to where the injection is. It doesn't get into your bloodstream and get distributed throughout your whole system to all bones. So I don't want to sit here and tell you that injections have no effect. If you had many of them over the years, I could imagine that it might slightly increase your risk of osteoporosis type stuff, but we actually don't worry about it very much because it's incredibly uncommon. The big worry is people who take a lot of steroids orally by mouth.
Okay, thank you so much. We've got a question about torn meniscuses. I don't know if that's the correct plural, but what the recovery like is of torn meniscus. And I would also add to meniscectomy. Is there potential for regrowth? What's that recovery like and long-term prospects?
All right, so this is one of the most common things I do. I primarily do knee and shoulder surgery. Meniscus surgery is actually the most common single surgery I do. Plural of meniscus is menisci, in case you wanted to know, but meniscuses is just as acceptable in my book. What the meniscus are, again, for anyone who doesn't know, they are these C-shaped cushions of cartilage. There's two of them in each knee, one on the inner half and one on the outer half. They're between your thigh bone and your shin bone. They're basically shock absorbers. They get torn more easily than you would like. I will take care of meniscus tears this month in everybody from 13 to 75 or 80 years old. They can happen in anybody. And what happens when they tear is, instead of having a nice smooth cushion in your knee, now you've got a little flap, and it kind of rubs and irritates and causes inflammation. It just causes pain. It's not really a dangerous situation. It's just uncomfortable. The reason so many meniscal tears get surgery is that the meniscus tissue has almost no blood supply, and that means it has almost no ability to heal itself. Once you tear a meniscus, it is torn. Now, we are learning that some people can live with a torn meniscus. The pain sort of calms down over time. And even though they still have the tear, if it doesn't hurt, we tell them, don't worry about it. We don't need to do anything about it. It's not dangerous. But that doesn't happen all the time, or even the majority of the time. So when we go in for a meniscus surgery, one of two things happens. The most common thing is what's called a meniscectomy, and that's just the medical term for trimming a piece of the meniscus. We trim the torn piece out. We smooth the remainder of the meniscus nice and smoothly so it doesn't catch or rub, and then we get out of there. That is what happens the majority of the time, because when you weigh in all the factors, whether the tear is in good enough shape, how big the piece is, what the patient's age is, usually one or more of those factor into, this is not going to be something we can actually fix. We just need to trim it. That's a very quick recovery. There's nothing to heal other than the two little camera nicks from your surgery. So get off your crutches in a day or two, or as soon as you're comfortable. Start your PT, get your motion going. I tell my higher level athletes, I expect you to be back on the field 4 to 5 weeks after the surgery. As soon as all your rawness is down, we're going to let you go to town. There's no actual restrictions. But not every meniscal tear is treated with meniscectomy or trimming. For better or worse, I am on the very, very far end of the aggressive spectrum in terms of trying to actually fix them, meaning sew meniscal tears back together. It can't be done in everyone. It's got to be a tear in the right place. It's got to be a big enough piece to make it worth it. Patient age may or may not play a role. That's sort of debatable. But the issue is, if someone has a big enough tear and you just trim it, you are removing a portion of their shock absorber in their knee. And the more you remove, we know 110% your risks of arthritis then go up significantly down the road. So if you can save the meniscus, you're better off long term. The problem is they don't all heal completely. So for instance, an hour and a half ago, I fixed a very, very large tear on a 58-year-old. It's kind of pushing the envelope a little bit, but it was almost his whole meniscus, and he had almost no arthritis now, where if I just go ahead and trim that out, he's going to get a partial knee replacement in 8 or 10 years. We're going to take the chance on getting this thing to heal. But he will pay for it in the short term, because if you do a repair, the recovery is much more rigid. You may be on crutches for a couple months. You may have to wear a brace, or not a couple months, couple weeks. I'm sorry about that. You may be in a brace for a few weeks. And the ultimate healing time before I'm going to let this fellow go back to cutting and pivoting and running and jumping is at least 3 to 4 months to give this thing a chance to heal. So long term, it's better for his knee, but short term, life's going to be a little bit more of an aggravation for him.
All right. Thank you so much. If anyone else has any other questions, please go ahead and send them through. And with that, unless we get any other questions, Dr. Battaglia, do you have any final thoughts or things that you'd like to leave us with tonight?
I'm embarrassed to say no, I don't think I do.
All right. Well, with that, I suppose we can say goodnight to each other. Thank you so much for this incredibly generous presentation. We've got a couple thank yous coming in. They're coming directly to me, but thank you so much, Dr. Battaglia, for this really robust, informative, and animated presentation. We really learned so much about so many different kinds of things. I would like to let everybody know that we are going to be I'm just going to add myself here. We are going to be sending you all a follow-up email with some more information that Dr. Battaglia provided tonight, as well as how to get in touch with folks at the SOS, and also more information about the Y. So please keep an eye out. And if you are interested in any of our upcoming speaker series, just let me know. I'd also love to receive your feedback. So again, thank you so much, Dr. Battaglia, and all of your colleagues at SOS, and to everyone that has joined us this month for our partnership with SOS. So good night, everybody. Enjoy this beautiful evening.
Thank you.
Good night.